Hello and welcome to our webinar, Millon Adolescent Clinical Inventory 2, Assessing Externalizing and Internalizing Patterns. Our presenter today is Dr. Robert Tringone, who is a licensed psychologist in the state of New York. Dr. Tringone worked under the leadership of the world-renowned personality theorist, Dr. Theodore Millon, for several years, co-authoring several books and personality assessments, such as the MACI and the MPACI. His recent research efforts have focused on developing measures to test Millon's theory of emerging personality patterns and their connection to parenting styles. We also have Dr. Gloria McCoo and Scott Pawson from Pearson on with us today, and they will monitor the chat box during the webinar. This webinar is being presented in broadcast audio. Please turn up your computer speakers to hear the audio. If you have dialed in, all phone lines have been muted to omit any background noise. If you're having any connectivity or audio issues, please click on the question mark at the top right hand of your computer screen for assistance. Please type any questions that you have into the chat box. We will answer questions live, time permitting. If we do not get to your question today live, we will follow up after the webinar by email. The webinar handout is downloadable under Event Resources to the left-hand side of your screen. Please fill out the survey that pops up at the end of the webinar for your certificate of attendance. After filling out the survey, you will receive an email from do-not-reply@webcast.com with the link to your certificate. With all that being said, I'll turn it over to Dr. Tringone.
Thank you, Sherry, and hello, everyone, and welcome to our second webinar for the Millon Adolescent Clinical Inventory 2. The first webinar in this series provided an overview of the MACI-II, reviewed the many changes that have been made to its predecessor, and demonstrated its interpretive sequence through a case example. If you are interested, a recording of that webinar can be found at the Pearson Assessment website, as well as video recorded responses to many FAQs for the new instrument. Today's webinar has an ambitious agenda, and I'm looking to offer an integration of theory, research, and cases that will further illustrate the MACI-II's clinical utility and the insights that can be gleaned from the revised interpretive reports. A targeted review of Dr. Millon's personality theory will be necessary, since it provides the foundation that separates the MACI-II from other adolescent self-report personality measures. Additionally, one's developing personality pattern provides the backdrop or context within which to conceptualize other clinical matters. Therefore, the more familiarity one has with the theory, the more one will gain from administering the instrument. Further, it is important to have a working knowledge of how the MACI-II scales relate to one another, as well as how the MACI-II compares to its predecessor and other popular instruments. The MACI generated scores of research studies. Could those findings potentially apply to the new instrument? Many subjects in the MACI-II normative sample were administered other instruments in order to establish the MACI-II's external validity. What associations were found between the MACI-II scales and the scales from those instruments? We'll review some of this information as well, and then I'll provide two case examples, one externalizing type and one internalizing type, toward the second half of today's webinar. MACI and Millon are registered trademarks of Dicandrian Inc., and the MACI-II is published and distributed exclusively by NCS Pearson Inc. A brief reminder for those who may have tuned in for the first webinar, but for those who are new, I do want to catch you up so you know what we're talking about. So what is the MACI-II? The MACI-II is a 160-item self-report inventory that has been designed to assess personality characteristics according to Millon's theory, as well as clinical syndromes in adolescents who are undergoing psychological assessment and/or treatment. Those evaluations can be psychological, neuropsychological, or psychoeducational in nature. While the MACI-II would ideally be administered at the beginning of treatment, it can serve as an outcome measure as well. What are some of the features of the new instrument? The MACI-II normative sample consisted of more than 1,100 adolescents. 48 new items were added in order to broaden the instrument's scope. It can be administered to adolescents ages 13 to 18. It is rated at a 4th grade reading level, is available in English and Spanish, including audio recordings. It usually takes 20 to 25 minutes to complete. The MACI-II has 2 combined gender normative groups: younger adolescents who are 13 to 15 years old, and older adolescents who are 16 to 18 years old. The interpretive and profile reports have been revised, and there are now 3 types of interpretive reports: male, female, and gender neutral. What are some of the important changes for the MACI-II? Many changes were implemented in its development. New validity scales have been created, which emphasize the detection of random responding and provide an indicator of whether a test taker may have under- or over-reported problems and potentially distorted the profile. Clinicians will be more involved in this determination since the MACI modifying indices have been removed. Concerns over the high degree of item overlap on the MACI were addressed by changing the item weighting scoring system from 0 to 3 to 0 to 2. The number of loadings across the test subsequently dropped dramatically. As a result, the clinical scales are much shorter than before. However, the correlations between the common MACI and MACI-II scales remain strong. Changes to the MACI-II personality pattern scales reflect advances and refinements in the test's underlying personality theory. New items were written for each personality pattern scale, and the borderline tendency scale is comprised of prototypal items that were written specifically to assess the construct. 3 new clinical syndrome scales were added to identify important conditions that reflect current clinical presentations among adolescents. Those scales include disruptive mood dysregulation, post-traumatic stress, and reality distortions. The simultaneous goals of increasing the clinical scope of the MACI-II while maintaining the 160-item test length led to the elimination of several MACI scales, including the doleful, body disapproval, sexual discomfort, social insensitivity, and impulsive propensity scales. 6 new items have been retained that do not load on a scale. Instead, they are included in the Noteworthy Responses section. All of us are aware of the need to identify those who may be at risk to engage in violent behavior. For this purpose, 3 vengefully prone items are included and seek to identify ideation, intent, and potentially planning one's revenge. There are 3 bipolar spectrum items also. While we had set out to create a bipolar spectrum scale, we were not able to do so, but elected to retain items that tap symptoms, including excessive energy with decreased need for sleep, extreme mood swings from highs to lows, and impulsive and reckless actions while in a manic state. And finally, from this slide, use of the word considerations was carefully thought out. The MACI-II offers DSM-5 diagnostic categories for the clinician or evaluator to consider, because they will ultimately decide what the most accurate diagnoses would be given other information that is available or known to them. And further, efforts were made when indicated to link personality pattern scale elevations to some of the clinical syndrome scales. For example, when an adolescent earns a score within the prominent range on the anxious feelings scale, a report will note that generalized anxiety disorder should be considered. Other categories, such as social anxiety disorder or separation anxiety disorder, will be added depending on personality pattern scale elevations. So what are the MACI-II scales? There are actually 24 clinical scales that are divided into 3 sections: personality patterns, express concerns, and clinical syndromes. There are 3 validity scales and 33 Grossman Facet scales. Each of the personality pattern scales has 3 corresponding Facet scales that assess aspects of the primary personality types. The Facet scales provide information on the most prominent domains for each personality type. The MACI-II validity indicators include the invalidity scale and 2 new validity scales named inconsistency and response negativity. The 2 items that comprise the invalidity scale have been changed, so they are now very direct inquiries regarding whether the adolescent is answering truthfully or not. We expect the score to be 0 on this scale. The inconsistency scale consists of 31 semantically similar item response pairs. It was developed to identify discrepant responses to items that are usually answered similarly. Each inconsistent response pair contributes 1 raw score point to the scale score. We expect scores to be in the 2 to 3 range most of the time. The invalidity and inconsistency scales rely on raw score cutoff points, and the combined invalidity inconsistency index is recommended for the detection of random responding. According to this index, profiles will be classified as valid, questionable, or invalid. And finally, the response negativity scale consists of 42 items, essentially 2/3 that are negative in content and 1/3 that are positive in content. And it was constructed so that high scores represent an undifferentiated pattern of negative responses across the items. In other words, high scores reflect a high number of true responses to items with negative content, as well as a high number of false responses to items with positive content. Raw score values are converted into percentile ranks, and clinicians will be interpreting these percentile ranks. For example, what would it mean for an adolescent to score at the 90th percentile rank on this scale? Could it be that the adolescent has an unusually large number and broad range of problems, like you might see with complex trauma or high levels of family dysfunction? Or on the other hand, does it represent an actual over-reporting or exaggeration of problems for some other reason? We have handed the decision-making back to the clinician rather than having a computer program make base rate score adjustments behind the scenes without knowing the context of the case. The MACI-II has 11 clinical scales that assess stable and enduring personality patterns. These patterns are the central constructs to all of the Millon inventories because they represent our overall capacity to perceive and to relate with our psychosocial world. MACI-II personality pattern scales have connections to many of the personality disorders recognized by the DSM-5, and you can go through them here on the slide. Within the Millon system, we emphasize that these constructs fall along a continuum. Furthermore, given that an adolescent's personality traits may change or fluctuate in either frequency or intensity during this stage of development, the MACI-II scale names are less severe, and elevations on the scales do not indicate that personality disorders are present. The asterisks on this slide prompt me to point out that the name of Scale 8A was changed from oppositional on the MACI to discontented on the MACI-II, and the name of Scale 8B was changed from self-demeaning to aggrieved. These scales correspond to the negativistic and self-defeating masochistic personality disorders, respectively. As noted before, prototype items were written for the borderline tendency scale in order to assess the construct with its own set of items. Please note the number of items per scale on this slide and the next 2 slides. The MACI-II scales are much shorter than their predecessors because of the change in the scoring system. However, this change did not alter the underlying structure of the test or the expected associations between scales. MACI-II also includes 4 scales that assess expressed concerns, feelings and attitudes about issues that tend to concern troubled adolescents. The first 2 scales, identity diffusion and self-evaluation, may be seen as self-oriented, regarding one's identity and confidence, while the latter two scales are other-oriented, regarding peers and family, how well one fits in, or how supportive others are perceived to be. The MACI-II includes 9 scales that assess acute and transient clinical syndromes. Clinical syndromes such as anxious feelings and depressive affect are often the initial focus of treatment. Also note the substance abuse proneness scale. Adolescents were willing to endorse alcohol and drug use items on the MACI, and it is believed this will hold true with the MACI-II. Behavior disordered adolescents will often, but not always, have an elevated score on the delinquent predisposition scale, along with the unruly scale and some other personality pattern scale. We'll revisit this idea with the first case. 3 clinical syndrome scales were added. Long-standing problems with anger, frustration tolerance, and impulse control are assessed with the disruptive mood dysregulation scale. Elevations on this scale indicate that an adolescent acknowledges having anger discontrol problems and that these lapses have had a negative impact on their family and peer relationships. For those working with adolescents who have experienced trauma, the post-traumatic stress scale places a heavier emphasis on trauma-related symptoms than its predecessor, the childhood abuse scale. These symptoms include having been in situations that triggered fear for one's life, experiencing or witnessing some type of trauma, and repeatedly thinking or feeling distressed about it. The reality distortion scale was added to assess for psychotic symptoms. Adolescents may endorse that they are questioning their grip on reality, have fears they are losing touch with reality, or may be hearing voices. Positive endorsements will alert us to these important concerns. Since the MACI-II was released just months ago, it is important to report on how the current version corresponds to its predecessor. Here we see that many scale pairs have strong correlations. 3 slides ago, the slide included the number of items for each scale. The MACI-II scales are much shorter. In fact, 9 out of the 11 of the personality pattern scales are now less than half their original length, and we still see these numbers. The lower values were obtained with those scales that underwent the greatest amount of change. The MACI-II Express Concern scales are much shorter also. All 4 are less than half their original length, and here we see the numbers with the correlations ranging from 0.89 to 0.95. And finally, the same holds true for the common clinical syndrome scales. All 6 of those scales that were retained have item totals that are less than half their original length. The anxious feelings scale underwent substantial changes in order to improve the scale, so it was anticipated that it would have the lowest correlation. However, the new scale has demonstrated strong positive correlations with anxiety scales from other instruments, usually in the 0.80 range. There are 12 noteworthy response categories. I noted the ventally prone and bipolar spectrum items before. The other categories are important in their own right, given they monitor safety risk, trauma, possible psychotic symptoms, anger problems, etc. It would be good practice to check this section each time you administer the inventory, regardless of whether a particular scale is elevated or not. So let's move on to looking at some things regarding externalizing problems and internalizing problems. The child and adolescent assessment field has a long history of categorizing clinical problems, whether behavioral, emotional, and/or social, into 2 broad areas, externalizing and internalizing. The Achenbach system of empirically based assessment and the behavior assessment system for children are 2 prominent examples that provide multiple scales and composite indices that fit this model. Externalizing problems typically include observable behaviors that involve some form of acting out, conduct problems, anger dysregulation, and/or aggression. These behaviors catch the attention of parents, teachers, and other adults, are disruptive in home and or school settings, have a negative impact on relationships with adults as well as peers, and bring possible harm to oneself or others. Internalizing problems, on the other hand, are typically less apparent because there are fewer overt indicators. They tend to be less disruptive in common settings and have less of a direct or immediate impact on others, and seem to represent distress that has been directed inward. Here's a quick review of the MACI and MACI-II literature in these areas on the 2 slides we're going to look at. Scores of studies were conducted with the MACI, and many focused on acting out or externalizing behavior problems. Consistent results were obtained when comparing the MACI with other instruments, for example, the Psychopathy Checklist Revised, or whether conducting factor analyses. It often was found that the MACI unruly, forceful, oppositional, now discontented, social insensitivity, delinquent predisposition, substance abuse proneness, and impulsive propensity scales clustered together. A subset of the MACI-II normative sample was administered the MACI-II and one of these other instruments portrayed here on the slide, so the following results are from 3 separate groups. Comparisons between the MACI-II and the MMPI-A-RF found that the MACI-II delinquent predisposition scale had the highest correlations with the first 4 MMPI-A-RF scales listed here: behavior externalizing dysfunction, antisocial behavior, conduct problems, and disconstraint revised. And the MACI-II forceful scale had the highest correlations with the 2 MMPI-RF antisocial attitudes and aggression scales. Meanwhile, the MACI-II unruly scale had the highest correlation with all 6 of these scales. Comparisons with the BASC-3 self-reported personality adolescent version revealed the MACI-II unruly scale showed the highest correlations, the forceful scale the second highest correlations, and the delinquent predisposition scale the third highest correlations with the self-reported BASC-3 hyperactivity, school problems, and inattention hyperactivity scales. The same 3 MACI-II scales yielded a very similar pattern with the Beck Youth Inventory's 2 disruptive behavior scale. And also, upon close inspection, the MACI-II family discord scale had much higher correlations with all the scales noted on this slide from these other measures than the MACI-II peer insecurity scale did. Correlations do not tell us about cause and effect. Nevertheless, there appears to be a clear association. It is important to be aware of all these relationships, in particular if you tend to use a multi-method approach to assessment. Many studies were also conducted with the MACI looking at adolescents with internalizing problems, in particular depression and suicide risk. The MACI scales that emerged on a consistent basis were the borderline tendency, inhibited, doleful, oppositional, and self-demeaning personality pattern scales, as well as the identity diffusion, self-evaluation, depressive affect, and suicidal tendency scales. Normative data on the MACI-II indicate that these same scales remain the ones to watch. Very strong correlations were found between the MACI-II scales listed here in the first column with the MMPI-A-RF scales that are listed there in the second column, with more than 1/3 of the correlations exceeding 0.75. A similar correlation pattern was found between the same MACI-II scales and the BASC-3 scales listed in the slide, with more than 45% of the correlations exceeding 0.75. And finally, matching up corresponding MACI-II and BYI-II scales revealed the depression scales correlated at 0.90, the anxiety scales at 0.82, and the MACI-II self-evaluation and BYI-II self-concept scales at 0.83. A close look at the correlations between the peer insecurity and family discord scales with the scales listed here from these other measures revealed that the peer insecurity correlations were substantially higher for each one, all 17, in case you're counting them up. Okay, now that we've covered some and how some of the MACI-II scales align with other measures, let's just think for a moment. What are some factors that could contribute to whether a child or adolescent expresses their distress outward and in conflict with the environment, or inward and against the self? As clinicians, we usually consider factors such as temperament, attachment style, early and ongoing parent-child interactions, early and ongoing peer connections, personal perceptions, cognitions, and expectations, role modeling, reinforcement patterns, biological proclivities and vulnerabilities, and others. While this list is broad, it's not exhaustive, but implicit in it is the idea that we as clinicians search for something to guide us toward understanding what we see and hear regarding our clients, and then intervening in an effective manner. If one approaches clinical matters from this perspective, then Dr. Millon's personality theory can serve as the guide on our journey, and the Millon inventories may serve as the roadmaps, or if I finally keep up with technology, the GPS systems. Did you know that each Millon inventory represents one component within an ambitious system that Dr. Millon outlined for us? Dr. Millon introduced his personality theory in his 1969 text, Modern Psychopathology. At that time, the theory was formulated as a biosocial model of personality development with a strong emphasis on positive and negative reinforcement. Over the next 30 years or so, with each edition of his 3 authoritative disorders of personality tomes, Dr. Millon's theory advanced to an evolutionary perspective. In 1990, his text, Toward a New Personology, was published, in which he outlined 4 central components of a clinical science that he referred to as personology. The first component, theory, provides a foundation and a model through which one can derive and explain clinical constructs that one observes. For our purposes, those constructs are personality types. For adults, they would be personality disorders. Taxonomy, the second component, points out the need for a classification system that assesses these constructs across the same clinical domains. In personality assessment, those domains include behavior, cognitions, self-image, object relations, moods, among others. A distinguishing feature has been identified for each type within each domain that helps differentiate them from each other. Instrumentation, the third component, represents how the constructs are identified by the theory, are then operationalized and measured, and that's where the Millon inventories obviously come in. And lastly, the fourth component, interventions, relates to treatment. According to the Millon model, treatment interventions can be formulated in regard to 3 central polarities from the first component, 8 clinical domains that have been identified from the second component, and what are called self-perpetuating processes that all personality patterns possess. At the polarity level, the personality patterns are formulated to have imbalances, conflicts, or deficiencies. At the domain level, specific domains, for example, interpersonal conduct, self-image, or mood temperament, may be more relevant or central to a particular personality type than others. And finally, at the self-perpetuating process level, each personality type engages in certain ways of behaving, thinking, feeling, and relating that set up situations and interactions that reinforce them. Dr. Millon's theory is based on 3 core polarities. The first polarity is the pleasure-pain polarity, which focuses on the nature or type of reinforcement. The The pleasure component focuses on the ability to seek happiness, to connect with others, pursue achievements, and enjoy successes, while the pain component focuses on the avoidance of danger, threats, sadness, anxiety, rejection, disapproval, among others. The second polarity is the active-passive polarity, which represents the modes by which an individual may elicit positive reinforcement or avoid punishment. Active personality types are characterized by their alertness, persistence, and proactive approach to eliciting or securing what they want or desire in regard to pleasures and rewards, or in regard to evading the distress of punishment or experiencing anxiety. Passive personality types, on the other hand, tend to exhibit an acquiescence to their environment and wait for others to take care of them, allow others to assume leadership roles, and expect good things will come their way with little to no effort on their part. Finally, the third polarity, the self-other polarity, corresponds to the source of the reinforcement. Some personality types have learned that feelings of pleasure or the avoidance of pain are provided almost exclusively by others, while other types have found that self-reliance and autonomy are necessary to ward off vulnerability and derive a sense of self-satisfaction. Over time, Dr. Millon advanced his theory to an evolutionary model, and the same three polarities, while conceptually modified, are combined and configured to identify, define, and explain the personality patterns that are measured by each of the Millon inventories. So what might these polarity configures actually look like? I'll present two personality types that I consider to be within the core four. One of these types is associated with internalizing problems and the other with externalizing problems. The first will be the submissive type, and you see it identified as an emerging dependent type. It is conceptualized as the passive dependent pattern because it is imbalanced toward the passive and other poles depicted in the slide with the strong orientation, the dark blue. Submissive types need and rely on others to provide guidance and support in order to feel safe and secure. There is a passive reliance on the goodwill of others, which brings them pleasure and helps them avoid pain. They tend to place themselves in secondary positions by depending on others for attention, support, and protection. They seek guidance and allow others to take care of them. They learn that others may be more competent than they are, which gradually leads to a lack of initiative, assertiveness, and self-confidence. These personality types are often raised in overprotective environments, where safety concerns and anxiousness are often expressed directly and sometimes subliminally to them. The pleasure-pain polarities are not implicated conceptually for this type, but as you might anticipate, this type is more prone to developing internalizing types of issue. Now let's consider the unruly personality type, which is conceptualized as the active independent pattern. Since this type is imbalanced toward the active and self poles, once again depicted in the dark blue, it essentially represents the polar opposite of the submissive type. Unruly types are driven by a need to self-aggrandize in order to achieve a sense of superiority over others. Their strivings for independence stem from an underlying mistrust. They believe only in themselves and are secure only when they are independent of those who they fear may undo, harm, or humiliate them. They are often skeptical of others' motives. Therefore, they desire autonomy and wish revenge for what they perceive have been past injustices. As a result, they may engage in clever, deceptive, and in some, but not all, illegal behaviors in order to exploit others for self-gain. You may have noticed on the slide that the unruly type is conceptualized as weak on the pain polarity. This stems from their impulsive, short-sighted, and spur-of-the-moment decisions and actions. They are prone to taking chances and seeking excitement with little planning or forethought of the consequences, and sometimes act as if they were immune from danger. So we've finished reviewing some of the theoretical and empirical backings of the MACI-II, so we're going to switch gears and now bring these things to light with two different cases. Let us first, though, outline the interpretive steps with the MACI-II so we can take this forward in a systematic way. For step one, as usual, we would start with basic demographic information. What do we know about this adolescent, his or her age, family system, cultural background? What are their peer relations like? How do they perform in school? What level of functioning do they show in various settings, in addition to, of course, the basic presenting problems that brought them to us in the first place? In step two, we have to start by checking the validity of the MACI-II profile. I noted before we would be looking at the invalidity and inconsistency scales, and then in regard to whether there were any distortions in the adolescent's approach to the test, we would check the response negativity scale. After reviewing those scales, we check the borderline tendency scale among the personality pattern scales, because it represents a severity gauge among those scales. Elevations on this scale are suggestive of more serious personality problems. Among the personality pattern scales, the borderline tendency scale has the highest correlation with which clinical syndrome scale? The suicidal tendency scale. So we definitely want to check in regard to the clustering of the borderline tendency scale, depressive affect, and suicidal tendency scale. For step three with the MACI-II, the personality pattern section will often have 2 to 3 scale elevations, and these scales will be interpreted together. In particular, we are looking for base rate scores that are 85 and above. Next, we would look at the Grossman Facet scales for those 2 to 3 personality scales that may be elevated, and the Facet scales help us to further refine our interpretation. However, we would actually look at all 33 Facet scales for further information. The personality patterns profile creates the context within which the expressed concerns and clinical syndrome scales will be interpreted. We would next review the noteworthy responses section, especially the vengefully prone and bipolar spectrum items. And at the same time, though, we want to check the items that assess suicidal ideation and self-injury and other areas of concern, even if those scales are not elevated. Elevations on the MACI-II clinical scales will translate into diagnostic considerations, and clinicians will synthesize information from other sources in order to determine accurate diagnoses. And finally, after synthesizing all of this information, we want to note that there are fully revised treatment guides for the MACI-II that address treatment targets, approaches, strategies, and modalities that could prove efficacious. So let's move to the first case study, which is 1866. This adolescent is a 16-year-old male who is involved in the juvenile justice system following his arrest for a series of thefts, including breaking into cars, shoplifting from department stores, and pilfering from the ice cream store where he worked part-time. School problems were notable also. He had been an honor roll student in middle school, but was now repeating 9th grade due to frequent truancy. A review of school records and interviews with his family revealed a long-standing pattern of disruptive behavior, impulsivity, hyperactivity, and a short attention span. It was apparent that he had met DSM criteria for ADHD combined type some time ago, but no treatment interventions had been pursued before. His family history includes that his parents separated when he was 1 year old. It was reported that his father could not hold a job in order to support his family, had legal issues of his own, and had been abusive toward this adolescent's mother. She worked and had supported her son as best she could while dealing with substance abuse problems, which persisted for many years until she became sober. She remarried when this adolescent was 5 years old. He initially connected with his stepfather, sharing an interest in sports. However, their relationship changed with the arrival of two half-siblings. Periodic anger outbursts were reported over his preteen years, but he was generally manageable until 1 to 2 years ago when he became more defiant at home, stopped applying himself in school, switched friend groups, and dropped out of organized activities. His parents were aware of his school problems, but were unaware of his illegal activities. This adolescent's abbreviated history suggests that he would likely fit in the externalizing behavior category. We might anticipate he would obtain a high score on the MACI-II delinquent predisposition scale also. While this might turn out to be true, what underlying personality pattern scales might be elevated? This slide presents some of this information from the MACI-II normative sample. It turns out that 56% of the normative sample who scored within the prominent range, base rate score equal to or greater than 85, on the delinquent predisposition scale, had the unruly scale as the first or second highest personality pattern scale. And in this slide, the unruly scale is scale 6A. Scale 5 is the egotistic scale, 8A is the discontented scale, 6B is the forceful scale. This finding, however, tells us that 44% of this subset had a different personality pattern scale as the highest scale. For our purposes, we are thinking that similar behaviors may derive from different factors. So it is important to understand who this adolescent is who engages in these externalizing behaviors. What dynamics might they stem from? What purposes do these behaviors serve, among other questions we would want to look into. So let's move to his MACI-II profile. This is a valid MACI-II profile. It is posted at the top of the profile page, and it is valid because the invalidity scale equals 0, and the inconsistency raw score is 3. A score of 7 on this scale would have made the validity of the results questionable, or a score of 8 or higher would have made the results invalid. The profile does not appear to have been distorted in a particular way, meaning there does not appear to be an underreporting or overreporting of clinical problems, because the response negativity percentile of 62 falls within the middle 50% of the normative sample, and the response negativity information is provided in the upper right-hand corner of the profile. That allows us to check the severity gauges, which include the borderline tendency scale, as well as the reality distortion scale. A base rate of 53 on the borderline tendency scale falls below the median of 60, and the base rate score of 17 on the reality distortion scale falls well below the median. Therefore, our findings will focus on the forceful scale, which is the highest, in tandem with the unruly personality pattern scale, and to a lesser degree the discontented scale, as well as delinquent predisposition, disruptive mood dysregulation, and family discord scales. Now, just a little information regarding the forceful personality type, which is conceptualized as the active discordant type. Within the 3 core polarities, this pattern is weighted toward the active and self-oriented poles, which is similar to the unruly pattern. However, there is an important difference that is conceptualized as a reversal. Note the arrows for the pain-pleasure polarity. What this suggests is that this adolescent operates under a guiding principle of outwitting others and exerting power over them before they can control him. He believes that vigilance and forceful proactive behaviors are necessary to prevent harm by others. He projects a strong and tough presence and wants to be seen as assertive, self-assured, and unafraid. He harbors a disregard for the welfare of others, non-empathic and self-centered attitudes, and a socially intimidating manner. Deep-seated resentments are projected outward, leading to frequent conflicts, antagonisms, and interpersonal difficulties. His desire to provoke fear and to intimidate others stems from his need to overcome a sense of inner weakness and to vindicate past injustices. Here is a slide that just shows the personality patterns. All MACI-II reports start with a description of some of the adaptive features of the adolescent's profile. Under his current circumstances, these features may be less apparent, yet he is assertive and self-assured, seeks to project a confident and self-reliant presence, takes pride in his candor and frankness, embraces challenges, and is quick to perceive situations from a competitive vantage point. Further, this adolescent anticipates that others will be critical of and hostile toward him, regardless of his behavior. As a result of this mindset, he often acts in belligerent and antagonistic ways. He justifies his defensive aggressiveness and sets in motion a vicious circle in which his ever-present tone of anger and resentment interacts with his expectations that others will be hostile toward him. His hostile demeanor typically frustrates others and may provoke them to react with hostility themselves, further reinforcing his perceptions and expectations. He is inclined to brood and hold on to grudges, not letting down his guard, not forgiving others, and attributing malicious intentions to them. Additionally, he can be impulsive, engage in risk-taking behaviors, and he seems undeterred by threats and consequences. He is averse to obligations and responsibilities and tasks to which he sees no immediate relevance or purpose. Frustrations can sometimes boil over into anger, discontrol, and aggression. Let's move on to the Grossman Facet scales. A MACI-II profile will present in graph form the 3 facet scales for the 3 personality pattern scales with the highest base rate scores. In this case, that's the forceful, unruly, and discontented scales, and the facet scales will be presented in that order. The report will include the interpretation of the 3 highest facet scales according to the percentile rank, and then in this case, follow the tiebreakers, since 5 facet scales reached the 99th percentile rank. One other way to consider these 5 facet scales is to see if they cluster within particular domains. In this instance, 2 measure expressive behaviors, 2 more relate to his interpersonal conduct, and 1 the mood temperament domain. Overall, the facet scales further highlight this adolescent's impulsive tendencies, which can lead to short-sighted and sensation-seeking actions with little regard for consequences. It is probable that the tedious nature of routines and school are very challenging for him. Interpersonally, he is abrasive and antagonistic. His interactions typically range from callous to combative. He is someone who moves against others and has a notable deficit in his ability to connect in a genuine way. Finally, his most common moods appear to be hostility, anger, and bitterness toward others. When you print out a report, you will have a page that includes all 33 Grossman Facet scales. For this case, in addition to the 5 facet scales noted above, 3 others surpass the 75th percentile mark, which is the point that is identified as interpretable, and you can see that in the graph. These scales include the interpersonally exploitive and cognitively expansive scales from the egotistic, narcissistic personality pattern, and the interpersonally attention-seeking scale from the dramatizing pattern. While adolescents who fall under the conduct disordered category are often described as narcissistic, owing to their self-focus and disregard for the impact their behavior has on others, in the MACI-II normative sample, less than 20% of this group elevate on the egotistic personality pattern scale. It is believed that this is due to how the construct is formulated within the Millon model. These adolescents feel superior because of their supposed talents and abilities and praises and accolades they have received from others. This case provides a good example of how the facet scales can assist in identifying narcissistic traits, even though the home scale is not elevated. Moving on to the express concerns section, his responses led to a very high score on the family discord scale. It is probable that serious family problems exist, and tensions have been running high for some time. He experiences a lack of support, understanding, and validation from family members. At this point, it is likely that he has difficulty seeing or taking responsibility for his role in these problems. So recall that a short while ago, it was noted that the correlations between the family discord scale and the unruly, forceful, delinquent predisposition, and disruptive mood dysregulation scales were much higher than the correlations for the peer insecurity scale with the same scale. Extrapolating on this point, it may be that a high number of adolescents with externalizing problems have more significant family problems than relation problems with their peers, although again, we cannot determine cause and effect, but can sense how this pattern can spiral. In the clinical syndrome section, we find the prominent elevation on the delinquent predisposition scale, which captures the primary reason for the evaluation. He had been engaged in illegal activities and had been caught. Additionally, we find another prominent elevation on the disruptive mood dysregulation scale. This elevation is suggestive of long-standing issues with frustration tolerance and impulse control. His anger discontrol takes various forms, which can be further differentiated by reviewing the noteworthy responses section. He endorsed all items under the impulse problems and explosive anger categories, and the majority of the instrumental anger items. In other words, his angry outbursts may be spontaneous and often out of proportion to a trigger, in response to some perceived slight or provocation, or purposeful and planned in order to inflict pain or suffering, or to send a message of some kind. Here we see the Diagnostic Considerations section and how the different scales correspond to DSM categories. The term considerations is key. The MACI-II does not offer definitive diagnoses. It is clear that this adolescent would be challenging to work with. The MACI-II interpretive report would provide an integrated treatment guide. Interventions covered include, but are not limited to, establishing a working rapport, managing trust issues, seeing others in less exploitive or threatening ways, improving emotion regulation and anger control skills, uncovering automatic thoughts and core beliefs, recognizing that his actions have repercussions, and developing forethought in order to think about long-term consequences. Treatment efforts would seek to alter the trajectory of his life from the path that he is on at this time. And now we'll transition to an internalizing case with a predominance of anxiety with some sadness. I believe this case is relevant to current times as we deal with the impact of COVID-19 on children and adolescents. In my region, schools closed in mid-March, and we were informed the other day that schools can reopen in September. I've been most concerned about those who are facing school transitions. A particular subset, the internalizing type, concerns me regarding how they will successfully manage this transition. Earlier, I outlined the submissive personality type. Let's add the inhibited type, which is related to the avoidant personality. The central aspects of this type are configured within the pleasure-pain and active-passive polarities. It is conceptually seen, as depicted on the slide, as the active-detached pattern. There is a diminished ability to experience pleasure, while at the same time, they have an exquisite sensitivity and overreactivity to social stimuli and anticipate rejection and humiliation. Their underlying anxiety intrudes into their thoughts, interferes with their behaviors, distracts them from pleasurable pursuits, and disposes them to distance themselves from others in a protective manner. The role of the self-other polarity is conceptualized to be of less importance in comparison to the other polarities. However, inhibited types often suffer from low self-esteem since they harbor a sense of inadequacy and have clear issues trusting others. This adolescent is a 14-year-old male from a single-parent home. His parents never married. He has a close and supportive relationship with his mother, while his father has been an inconsistent presence in his life. He is an only child who lived near extended family and saw them on a regular basis until they moved away a year ago. During his first years of middle school, he struggled academically and socially. He had been bullied numerous times. The latter issue had been brought to the attention of school officials, but efforts to keep him safe were not consistent or very effective. Therefore, he and his mother moved midway through this past school year. It seemed to have been that he was making a good adjustment to his new environment. However, distance learning started not long after the move, so his contacts with new peers were limited. He faces a transition to high school when schools reopen. So let's take a look at his MACI-II profile. It is a valid profile because the invalidity score is 0 and the inconsistency score is 1. His response negativity score falls within the upper half of the middle 50%, so we don't believe that there has been an over-reporting of problems that would distort our overall findings. Also, the borderline tendency and reality distortion scales both fall below the median base rate score of 60. So we don't have that severity gauge. A scanning of the clinical scale sections reveals elevations on the inhibited and submissive scales, in addition to elevations on several expressed concerns and clinical syndrome scales. The prominent elevation on the anxious feeling scale is most notable, with a relative elevation on the depressive affect scale. Some might expect these scales to be closer, since clinically these conditions often co-occur. On the MACI-II, these scales do not share any items. That means no prototype items from the anxious feeling scale serve as a subsidiary item on the depressive affect scale, and vice versa. And yet our normative data has revealed a 0.67 correlation between these scales. For this adolescent, some adaptive features include his strong wishes for acceptance and closeness. He tends to be sensitive and cautious. He typically seeks cooperative relationships based on safety and trust. He tends to be very selective of his friends and wants to avoid conflicts. He is less assertive than most peers and needs reassurances to take chances. He is pensive rather than impulsive and typically demonstrates good self-control. These features will assume a different quality, however, when the inhibited and submissive scales are elevated as much as they are here, and when he faces challenges to his sense of safety and security. Under such circumstances, his desire for acceptance will be accompanied by persistent apprehension and fearfulness, as well as worries about how others will respond to him. His underlying wish to connect with others will be impacted by his low self-confidence and a heightened sensitivity to rejection or embarrassment, which may be manifest in shyness and hesitation with peers. An inner struggle ensues between wanting to move toward others, which may be thought of as an internal desire, and moving away from others, which would be seen as in his external self-protective stance of maintaining a safe distance. A review of the Grossman Facet scales would further expound upon these findings. Moving on to the express concern section, the highest base rate score was found on the peer insecurity scale. This score suggests that he has a sense of rejection from his peers, as well as feelings of loneliness and sadness over not gaining acceptance and approval for them. In the clinical syndrome section, we see the impact of these underlying issues as manifest in a heightened sense of anxiety and periodic sadness. This adolescent's profile leads to the following diagnostic considerations. Again, these are not definitive diagnoses. And note that several possible anxiety disorder diagnoses are listed. General anxiety disorder is for the anxious feeling scale, while social anxiety links the anxious feeling scale and the inhibited scales, while the separation anxiety is often considered because of the elevation on the submissive scale. A treatment approach with this adolescent would include validation of his inner conflict between moving toward and moving away from others, which is seen at the polarity level. At the domain level, we would want to improve his self-image and self-esteem through recognizing his strengths, aptitudes, and interests, discuss his concerns and expectations regarding trust and social interactions, identify unhelpful thoughts, and teach him to challenge them with more realistic and optimistic ones, among others. At the self-perpetuating level, we would outline the cycle of anxiety and seek to mitigate its impact on him as well as to counter his withdrawal tendencies. And that concludes the prepared commentary for today's webinar.